Welcome to MedHurry. I'm your host, and today we are breaking down a monumental shift in clinical practice. The 2026 guidelines and trials have arrived, and they are redefining how we treat the intersection of heart, kidney, and metabolic health. This is the 2026 Clinical Summit, research that changes practice, delivered now. We have a lot to cover. Our headline story is the first ever joint guideline for CKM Syndrome. We'll then dive into the major updates in dyslipidemia management, and finally, we'll look at the 7-year PARTNER 3 data that finally settles the debate on TAVR durability in low-risk patients. Let's start with our headline, CKM Syndrome. For decades, we've treated heart failure, CKD, and diabetes as separate entities. No more. The ACC, AHA, ADA, and ASN have finally converged. They've recognized that these conditions are interlinked through a systemic metabolic disorder. This guideline isn't just about management, it's about preventing that cross-organ destruction. The hallmark of this guideline is the new staging system, from 0 to 4. Stage 1 starts with excess adiposity or early metabolic risk. Stage 2 adds CKD or metabolic syndrome. By stage 3, we see subclinical cardiovascular disease. Stage 4 is clinical heart failure or kidney failure. Staging forces us to intervene while regression is still possible through lifestyle and targeted drugs. To support this, we have a new tool, the PREVENT equation. It replaces the old 10-year ASCVD risk estimator. Why? Because PREVENT integrates eGFR and albuminuria and adds heart failure as an endpoint. It also gives us 30-year risk projections. For a 40-year-old patient, a 10-year risk might look low, but their 30-year risk can be a wake-up call for aggressive therapy. Therapeutically, the guideline is clear. GLP-1 receptor agonists are now foundational for obesity and diabetes with CV risk. SGLT2 inhibitors are the mandatory organ protectors for heart and kidney benefit. We are moving toward a standard where RAAS inhibition and metabolic agents are used together, early, to stop the CKM spiral. Our MedHurry score for this is 98. This is a practice transformation. The takeaway for tomorrow morning: you must screen for CKD in every cardiovascular patient you see, and you must assess cardiovascular risk in every CKD patient. Coordinated care is no longer a luxury, it's the standard. Next, the 2026 lipid guidelines. The updates reflect major data from the last 2 years. We are seeing a much broader focus on all atherogenic lipoproteins, with numeric LDL goals making a strong comeback for our highest-risk patients. The bar has been raised. For very high-risk secondary prevention, we are now targeting an LDL of less than 55 milligrams per deciliter. For high-risk primary prevention, less than 70. And for those borderline cases, coronary calcium scoring is now the essential tiebreaker to decide who actually needs that statin. But here is the real practice change: universal one-time lipoprotein A screening. Every adult should be checked once. Why? Because 1 in 5 people have a genetically high lipoprotein AA that remains invisible to standard LDL tests. This identifies high-risk patients who need aggressive overall risk management while we wait for specific lipoprotein A inhibitors. Now, structural heart disease. The PARTNER 3 7-year outcomes were just published in the New England Journal. This was the trial that put TAVR up against surgery in low-risk patients, and we've been waiting for this long-term durability signal. The results are definitive. At 7 years, the composite of death, stroke, or rehospitalization was 34.6% for TAVR and 37.2% for surgery. The difference was not statistically significant. This confirms that for low-risk patients, The early benefit of TAVR doesn't come with a long-term penalty. Valve durability was also a no-show for failure. Mean gradients were identical at 13 millimeters of mercury. This data provides the confidence we need to offer TAVR to younger, low-risk patients. Shared decision-making should now center on fast recovery and excellent 7-year stability. In our first roundup, we have MAPLE-HCM and PROCTOR. MAPLE-HCM shows aficamten monotherapy is dramatically superior to metoprolol for improving exercise capacity in hypertrophic cardiomyopathy. And the PROCTOR trial? It actually suggests that when a bypass patient needs PCI, intervening on the vein graft is safer and more effective at 1 year than the native vessel. Finally, iMODERN and vitamin K2. iMODERN tells us that staged, CMR-guided PCI is just as safe as immediate complete revascularization in STEMI. And for prevention, we have the first randomized controlled trial showing vitamin K2, specifically MK7, can significantly slow coronary calcium progression over 2 years. What should you remember? CKM is a unified syndrome. Use the PREVENT equation, not the old ASCVD tool. GLP-1 receptor agonists and SGLT2 inhibitors are your workhorses. TAVR is durable. And check Lipoprotein A once. Start transitioning your risk tools this week. Mandate eGFR and albuminuria for all cardiovascular patients. And push those LDL goals lower. 55 is the new 70. 2026 is the year of integrated care. We are finally treating the whole patient, heart, kidney, and metabolism as one. This evidence-based approach is how we stop disease progression and save lives. This is MedHurry. Stay informed, stay critical, and change practice. Subscribe for our weekly breakdowns of the research that matters. We'll see you in the clinic.